Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome, everyone, to another episode of The Pursuit of Health. I'm your host, Rainier Schur, and joining us back on the show is Jared Rhodes. Welcome back, Jared.
Welcome. Good to be here.
So we're having you on today, Jared, to discuss a project that we've both been working on, and that is the Health Freedom Index. What is this project that we've been working on? And just tell our audience a little bit about the history of this project.
Sure. Yeah. So this is a 50-state analysis. It's actually 51 because we do Washington D.C. as well, but let's just call it a 50-state analysis for ease. And it is basically an analysis and an assessment of the policies that these different states have in place with regard to healthcare. And what we're trying to kind of measure here is which states are the most open, which of the states are the least regulated and most free states when it comes to various parts of healthcare. I'll say at the outset here, we look at lots of different variables. We call them variables. You could think of it as like a policy area, but it's we look at about 54 different things for each of the 50 plus one jurisdictions, states. And we give them a ranking. And so the sort of high level, result of this is a ranking of all the states. And so we can say like, such and such a state, this is the freest state in terms of healthcare, and this other state is the least free, right? And then we have, of course, the whole ranking in between. And what it does is it gets you a kind of a conversation that started with this. You can approach people in the legislature. You can approach the governor's office. You can talk to state think tanks that work in these various states, and it's kind of like I said, it's a conversation starter where you can say, hey, look, did you know that your state was number, I don't know, 9th or something like that, and that could be that so you're doing pretty well, right? You're more free than other states. But there's maybe some room still for improvement. Or if you by contrast, you approach somebody and you say, hey, look, did you know that your state just ranked 47th out of 50, right? I mean, that's sort of jarring, right? And presumably, most people would want to know why, or like, well, why are we bad, and relative to this scale. And so it's sort of like a conversation started where then we can get in and talk about the kind of policies that we want to explore as policy ideas and things that we might want to advocate for.
Yeah. So the best kind of comparison to this, to something that people might be familiar with, is something like the Economic Freedom Index, right?
Mm-hmm.
Where you can see different countries on like how free they are in regards to their economics. And I think it's something like that I convinced my wife, for example, that there's a correlation between, for example, free markets and prosperity, right? Because you look at the lack of freedom, and it correlates pretty well with like the poorest countries, and economic freedom, and all those tend to be the richest ones. So these rankings and maps, like we provide maps and whatnot, it can be quite powerful. But something like this is more targeted to people that work in state level health policy. So just tell me a little bit about the value to people working at the state level. And in fact, we have a older version of this as well, where like people have expressed that. So like maybe tell us a little bit about the history of where this report came from.
Sure. Yeah. So the comparison to other freedom indexes, let's say, is a good one. You mentioned the World Freedom Index. There's also there's ones on things like free speech, right? Like the which countries have the greatest free speech and that sort of thing. And again, yeah, you can see the correlations, and you can it's even just fun to look at, right? And to think about the different states, or in those countries and how they compare. In this case, the background on this is that about I guess it was about 10 years ago, the Mercatus Center. I was an affiliated scholar at the Mercatus Center, and we put out the first one, or sort of like a first version of this. At the time, we called it the Hope Index, HOAP, and that stood for Healthcare Openness and Access Project. We were sort of thinking, oh, maybe it'd be a good thing to call it something other than a freedom index. There's trade-offs in how you talk about these things and brand them and stuff. But so we called it the Hope Index, and we had, at the time, I think we had like 36 or so variables, and we ranked the states. And then what we ended up doing then is having calls with, for instance, people at state policy think tanks. They are looking to understand what are the opportunities. How does their state compare to other states, and what are the opportunities for doing something better in their state, and honestly, just having like a list of 36 different variables where you might not even realize what some of the variables and what some of the policy levers are at in healthcare. The a state, healthcare is very much a state state by state kind of regulated thing. Of course, there are big and important things that happen at the federal level. Don't want to deny that or anything, but a lot of it, and possibly an underappreciated amount of it, of healthcare, is kind of controlled and regulated at the state level, and so there's a lot of policy levers to pull. And so, providing in the course of coming up with the rankings, providing the list of all the variables and those policy levers is something that can be eye-opening just in itself, right? Like, you might not realize. If you're in healthcare, you've probably heard of nurse practitioner scope of practice. That that would be like one example of a variable or a policy lever, right? But if you're an incoming state rep, and you don't particularly have a lot of experience in healthcare, but you think you might want to be involved in it, or you've been assigned to the Health and Human Services Committee or something like that. Well, this is a way to learn what some of those policy levers are. Maybe you didn't know much about like licensing, or there are people who are serving in state government who have don't know what a con law is, a certificate of need law, right? And so this kind of report provides that kind of like educational opportunity to get some people up to speed on things if they want to do a deep dive into healthcare. And a lot of times, state legislators, especially this time of year, right? This kind of August release of this report coming up here is not by accident, because generally from sort of like late summer until maybe December or so is the time when many, not all, but many state legislatures are starting to convene, and they have and there's oftentimes deadlines by which you have to kind of submit your rough idea, and then you can get it turned into actual model language and everything, and then even deadlines on when you have to submit your actual bill and that kind of thing. And so this is the season when people who are in state government are kind of like looking around for ideas, and if we can provide some resource for them to go to and see some of those ideas, then it can move the needle potentially in the right direction.
And I think it's worth emphasizing for our audience that even though there's many great people in these free market think tanks on the state level, a lot of them don't have dedicated people focusing on healthcare alone, right? They'll be covering health policy, welfare, taxes, and so their job is very hard. It's an unenviable position to be in. And so the way that I also see this report is that we're trying to provide a resource to them, right? Because they're trying to move their states in a better direction for healthcare. They're very often interacting with state level representatives. And so we definitely want them to benefit from a resource like this, because if you want to move your state towards more freedom in healthcare, you you need data and you need facts, and there aren't many resources. I mean, there are resources that'll tell you about the state of healthcare in your state, but not necessarily from the perspective of freedom, right? And so that's definitely I think a very valuable element of this report. And yeah, one of the main things that I'm looking forward to after this report comes out is opportunities that this will create for us to interact with those state level health policy people as well.
Yeah, yeah, totally. So those state level think tanks, they have good relationships oftentimes with state reps and state senators and everything, and the state reps and state senators will probably reach out to them first and I mean, maybe they, we're developing those kinds of relationships too, but it's a closer relationship with your local state think tank, and so they might reach out to them, the people at the think tanks first, and then if they have our report, they can look things up, or they can refer back to us, or we can all jump on a call and have a conversation, and that sort of thing. So we can all work together as well. And it's it's a good resource and a good kind of like, whether it's think of it as like a hypothesis generator or just an idea generator. It also you can also look at the scorings for these things. Up until now, we've been basically talking about the just the categories and the kind of variables themselves. But like, you can also look at the scoring, and there's a value there too, because if your state is already getting full points, like a good score on some area, that you don't have to waste any effort as a state rep to go do anything more on that. You're already doing well. You can actually scan the scores for, okay, well, where did my state get a 3 out of 5 and a 1 out of 5 or something like that? In other words, less than full points on some policy lever, and then you can kind of just like look for the opportunities instead of having to like sift through all of state healthcare policy, and sort of like learn from scratch where your state needs help.
Yeah. So we're definitely not going to go through all 54 variables. That's way too much. But I do think it might be interesting for our audience to get a sense of how we're kind of carving up the very phenomenon of health freedom, right? So like, what are the main kind of categories that we're looking at in this report?
Yeah, so we've got 5 broad categories. So the 54 different variables are sort of chopped up into and put into these different categories, roughly equally, although it's not exactly 54 divided by 5. That's not an even number. But those 5 broad domains are, first of all, professional freedom. Secondly, institutional freedom, and there were sort of thinking about like things that would apply to a facility or a hospital, that kind of thing, like institutional. We have to make it kind of broad to get some of these variables to kind of make sense to stick together. But institutional being the second one. Patient freedom, so things that kind of directly relate to the patient being able to do something or not easily is the third category. Payment freedom is its own category, because there are some things that just they purely relate to the money transfer for how you can spend money, how you're allowed to save money or not for healthcare expenditures. So that's payment freedom. And then the fifth one is delivery freedom. And that kind of pertains to like specific modes of delivery. There's a few telehealth and telemedicine variables in there, as well as like direct primary care variables. That's sort of the place where we thought it made most sense to kind of clump them together under delivery freedom. So those are the sort of 5 broad domains. Should we go through, I don't know, just a couple of sample,
Sure.
things? And yeah. So for instance, let's see, in the professional freedom, here's I mentioned nurse practitioner scope of practice. That's sort of like a classic a variable that some of our listeners might already know a little bit about. So I'll start there. That's that's a variable that we put in the professional freedom category, and there. so it's every variable has a 5-point scale, but some of the variables it's divided into like five discrete scores, one or a two or three or four or five. Other ones there's really only maybe like three different ways that a state can go, and so you have like a one or a three or a five. There's even a few where it's more of like kind of dichotomous. It's just either you recognize some freedom there or not, and so in that case we give a five to the states that we think are doing a good job in that, and a one to the states that aren't. With regard to this nurse practitioner's scope of practice, this one we have it as a 1-3-5 variable. So if your state has a really restricted scope of practice, you really don't let the nurse practitioners do a whole lot. They really just do the absolute minimum that they're kind of like legally like a lot that they're trained to do. You require that there's a lot of supervision by other physicians, et cetera. You don't kind of heap a lot of regulations on them. We consider that restricted. And we will give that state a 1 point on that variable. If you're sort of in between, if you're like a reduced scope of practice is what we call a 3. So in some areas you allow the nurse practitioner to do a little bit more, but in other areas you do still require some supervision and that sort of thing. It's maybe not as bad as the really restricted states, but you're not really at full scope yet. Well, there we'll give your state a 3. And then other states where you can really, the nurse practitioners they can open up, they can practice really independently. They basically have full scope of practice. We think that's a good thing. Obviously, these are kind of like normative assessments about what we think is good, relative to freedom being the standard of goodness here. And we consider, okay, that's good. That's full scope of practice, full points. So any state that does that would get 5 points. So that's an example of just one variable. Now imagine doing that for 53 other variables, and that's how we sort of how states accumulate points or lose points in different areas, and then out of that the rankings come. We could do. Let me touch on maybe one or two more. Let's see. We have on the institutional side, we've done a lot of things about certificate of need, right? That's a really important area of state level healthcare. If you're one of these states that has repealed its con law or never had one to begin with, you have no con law in place, so you're not requiring existing facilities and entrepreneurs to seek permission from the state to open a new facility or to expand an existing facility or to buy additional equipment. If you're not a con law state, you get full points. We view that as a pro freedom kind of position. So full points, you'd get a 5 in that. If you have if you technically do have some con laws, but it's only for a few different services, it's really sort of like pretty pretty tightly pretty narrowly implemented. You just do it for a couple of things. Maybe it's just for like ambulances or something, but you leave the hospital scene is totally free or something like that. Well, you're almost at full freedom, so we'll give you a 4 out of 5 there. And then down the line, we actually have like 5 different gradations. So if you're sort of middle of the road, you might get 3 points, or if you've got mostly, or if you have a lot of con law, a lot of different services that are subject to con law, then you might get just 1 point in this variable for certificate of need restrictions. Anyone that you that's on your mind here?
I mean, I think probably my favorite variable, which has to do with whether or not Medicaid allows parallel practice.
Oh yes, yeah. Let's
That's
go down to that
one that I want people to know more about.
Yeah, which one what, I'm trying to
I
scroll
think
through
it's
the
under payment because it involves both providers and patients.
yeah, is it number 44? State allows Medicaid patients to engage in direct pay for covered services. Yeah, we think states that would allow Medicaid patients to engage in direct pay for covered services would be a good thing. And so, if your state expressly does allow Medicaid patients to pay doctors directly for a service that is already, might already be covered in Medicaid, we think that's a good thing because that's good for access. It helps to alleviate the problems of, oh, I've got a Medicaid card, but I can't find a doctor because no doctors are interested in doing this, right? And it's also good for physicians that are practicing under this model, and allows them to innovate and see more patients in more different ways. So if you're a state that has that allows that, then 5 points to you. Um, there's we score this one as a 135, and so there are definitely states where this is just like expressly prohibited. And then there are some states that have sort of no law prohibiting it, but it's not necessarily clear, and they haven't gone after people for doing stuff, and so there is kind of like a gray area, and we create a three options. So in case any states fall in that area, we can sort of recognize that they haven't gone out of their way to prohibit something, although it's not as good as having like an actual safe harbor or an actual policy in place that allows it expressly. So this is a 135 variable, and this is an example of one of the new variables. I mentioned that years ago we did a version of this from the Mercatus Center, and I was part of that effort that put out that initial one. It was with co-authors Robert Grayboys and Darcy Nicole Bryan. We put that out in 2016 or so. We updated it once or twice after that, um, and oftentimes the most of the variables stay, have or appear in each version, but occasionally there are variables that will retire because they don't make sense anymore, or all the states are doing the same thing anymore, so there's no variation to capture, and it doesn't make sense to have it. Or just new issues arise. And I think this is an example of one of those things where it's sort of like a new idea, wouldn't call it an issue. It's more like a new opportunity, a new idea, new innovation that could arise, a policy innovation. And so this is one of the new ones that appears in our much expanded version, right? Like 54 variables versus 30 so is quite an expansion. So this is a bigger index than we've ever had before. Excited about it.
Yeah, and I think the one on scope of practice for nurses is interesting one to hone in on. Just to clarify, like our general approach to freedom in this report, right? Because you might think like, hey, like, isn't it the fact that they still have licenses at all still like shouldn't that count against them? Well, that's outside the Overton window at this point. So we're going to count anyone that recognizes nurses' ability to practice at the top of their license
Mhm.
as the freest thing that's available right now, right? Like, so, like, who knows? Maybe in 50 years in this report, then we can include like, okay, this state has gotten rid of like state level licensures and they've like deregulated and privatized it so that companies do it. That's not on the table right now.
Yeah.
So, like, in that sense, we want to capture freedom, but in a way that's actually relevant for people working on policy.
Right. Yeah. Yeah. The scoring and the sort of rubric could change over time if states take these kind of leading roles, right? Like you could, if your state jumps out in front and does something pretty bold, you could actually redefine this in a good way, right? Like you could do something that's almost like off the charts pro freedom. and kind of requiring us to kind of shift the rubric because you've done something that we applaud but weren't even expecting, and so that's good. Yeah, yeah. In general, I mean, the tool is supposed to it's intended to be helpful. It's intended to be a, something that you can learn some new stuff from too. I mean, even if you're in health policy, I guarantee at least a few of these variables will be new to you. There'll definitely be some that are very familiar to you, like individual mandates for health insurance, or coverage mandates for health insurance. Those things have been those are ideas and sort of aspects of state health policy that have been around for a long time. But there are other things that that are relatively new variables to look at, and there are even some. I'll even say this: there are some that are sort of like tough calls to make. That we've debated internally, like what's the good way to deal with PBMs, for example. That's kind of a tricky area. Or what's the good way to deal with private equity? What's good and what's not there, and that's and so we've covered that in here, and for anybody who is a fan of most of what we're doing, but might disagree with us too. I'll even say this, which is that we are going to be putting out the actual numerical scores of everything, of all the states and all the variables in a spreadsheet format. And look, if you disagree with us on something, you're welcome to download that and then run your own analysis. And if you think that something should be different, you could reverse score a variable, or you could modify some state score if you think we have it wrong. And kind of, now I don't actually think state rankings are going to change all that much. I don't think it's that sensitive to small changes here and there. But we do want people to download the data and even play with it, and feel free to write their own sort of like derivative articles on things and analyses. Maybe some subdomain is really what you think is really interesting, and so you want to just see, well, what does the ranking look like just for these 10 variables, setting aside all the others. This also leads into the issue, which anybody listening to this who's like kind of wrangled data before, it might be thinking to themselves, was there any weighting done, right? Like that's a really insightful question, which I'll raise and then answer, which is that no, not really. And the reason why we don't kind of weight some variables in the calculations of the scores as being more important than others is because it's a bit of a slippery slope. It's hard to do that once you start saying that, hey, this variable, this really determines a ton of healthcare, and this other one is kind of like it's a minor side issue. Yeah, it's important, but it's not that important. And so therefore I'm going to have a much heavier weight of importance to this first one. Once you start doing that, well, then you're really starting to put some judgment calls in there, and we didn't want to do that. It's of course you could do that a little bit, but we would rather just sort of put out like kind of like a flat, easy to understand tool. And then if other people want to do some weighting on those, and what I mean is WEIGHTING weighting, people are welcome to that. In fact, we might even do that. Like we might, after a couple of months after we put out the main report, we might go back and say, hey, surely insurance coverage mandates are more important than the Good Samaritan liability coverage, right? Which of course is something, but not that doesn't move mountains and say or determine the flow of tens of millions of dollars in quite the same way that insurance coverage mandates does. And so therefore, maybe we'll go in and we'll give more importance in the scoring to one other instead of the other, and then see what changes. Do we get a new top state if that changes, or does some other state, who used to be at the bottom of the rankings, do they all of a sudden jump up? That would be interesting. That'd be cool to know, I guess. But for the sake of like putting an initial version out there, we don't want to sort of complicate things too much and have things be it feels like a lot of the number calculations were like behind a curtain and hard to understand. We'd rather put out something that's like pretty simple and straightforward, let people play with it, and then we can always go back and do follow-ups as we desire. So
Yeah, and I think that plays into the kind of spirit of the report in general, is that we want this to be valuable to the community of people who want to move their state towards more freedom um, in healthcare, right? So like they might have interesting insights for us to point out, like, hey, like this doesn't really capture the lack of freedom in my state, and then
yeah.
like that can be used to update future reports. So we definitely want this to be an iterative process that's helpful for the wider community of people interested in freedom in healthcare. And speaking of which, we aren't the only ones behind the report as well. So, like, how about telling the audience a little bit about the people that we've been working with on this report?
Yes, thank you. I wouldn't want to forget. We did this. We teamed up with the Knee Regulatory Center. In particular, we've got great colleagues in Alicia Plemons and Drake Thibodeau, and their team of PhD students and everything. They run a great organization that's it's a research center that's associated and tied with West Virginia University. And so we teamed up with them. We divvied up the tasks in the project in various ways, but they did a lot of the sort of like the some of the data wrangling and everything, and some of the scoring, and they have a lot of good sort of like data sources that they have maintained over the years and everything, and so they've got some great capabilities in that. And so when you see the report come out, it'll be co-branded between us, Center for Modern Health. We were doing a lot of the data definition and the rubrics and setting up the which variables to include and what some of the potential data sources could be in some of these cases. And in a few of the cases, we did the scoring on them as well. But yeah, it's definitely a team effort between us and the Knee Regulatory Center, and they've been phenomenal partners in this. It's been a lot of fun to work with them. And so, yeah, you'll see it's co-branded between the two of us, and the document itself will be available on both of our websites, and we'll be cross-linking and everything, and so that you can find it in either place. But yeah, it's been great to work with them.
And how about telling us a little bit about where this report will be unveiled?
Oh yeah, so we are literally going to be unveiling it in a couple of weeks here. In Orlando at SPN, that's the State Policy Network's annual meeting, which is they call it a meeting, but it's really kind of a fairly large conference. Actually, it's a great thing. I've been to it one time before, a long time ago.
Maybe explain to the audience what the SPN is.
Yeah. So SPN is an organization that is sort of like an association or an umbrella organization that brings together all the different state policy think tanks, because not every state, but most states have a state policy think tank of some sort that's free market oriented, and so SPN is kind of the network that brings them all together. It's at least once a year with the SPN's annual meeting, but of course they do other stuff beyond that as well. And so, we're looking forward to connecting with all those state-based think tanks and the people that work in health policy, whether it's their sole job, which is rare, or more common, as you said, they're juggling a couple different issues. They're in charge of multiple things, and so this is a big help to them, because everything that we can provide to them is one less thing that they have to go out and like search and come up with themselves. So yeah, we're looking forward to unveiling it there, and then thereafter, or probably the same day, actually, it'll go live on our website and the Knee Regulatory Center's website.
I think that's an excellent place to end. I'm sure this report will come up again on this podcast and on our website where we talk about various aspects of it. I'm sure it's going to lead to opportunities to have state level representatives or people at think tanks coming onto our podcast. And so, yeah, we are looking forward to that. So I'd like to thank you, Jared, and our audience. And till next time.
Thank you.
To stay up to date, subscribe to our show from whatever podcast platform you are listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.